I'm going to be doing a presentation on reducing fall risks for school. The main thing is with the National Patient Safety Goals, they come up with several goals for patient safety that are used nationally. The Joint Commission makes these. One of the goals for 2016 is to reduce inpatient falls, reduce the risk for falls. Approximately 30% of falls result in injury overall, and falls with injury result in non-repayment by CMS. It increases the length of hospitalizations. Post-op orthopedic patients are at even higher risk than the regular patient population. They have a 13% risk of injury with their falls. It also causes them to have decreased mobility because they fear falling again, and then it increases litigation risk for the nurses as well. The importance of reducing the risk of falls is that it improves patient outcomes. Safety has to be a commitment of all employees. Just in healthcare in general, the idea is to do no harm to the patients. Reducing the risk of falls also improves CMS reimbursement, which helps with cost effectiveness because we're able to get more reimbursement, which allows us to have supplies for the patients. It reduces the risk of injury and death for the patients. It decreases the patient's length of stay. The length of stay goes up, like if they have an injury and redamage a knee replacement or a hip replacement and they have to go back to surgery, they require more antibiotic therapy to help reduce infection and that type of thing. It also improves patients' perceptions. If a patient falls while they're in the hospital, they feel as though they haven't had a good hospitalization because they should have had their needs met in a way that caused them not to fall. Because it reduces the fear, it improves their mobility overall because they feel safer moving around because they haven't had a history of falls. Sorry, not fast this. Let's see. So the case study that I used to just go over this, it's a fall risk associated with nerve blocks. It basically shows that nerve blocks increase the risk of falls in post-operative patients. They compared data to from 2003 to 2005 and then 2007 to 2010, and it just compared because 2003 to 2005 they weren't using the nerve blocks yet, and then 2007 to 2010 they had started using the nerve blocks, and they found that in the patient population that there were no falls prior to the use of nerve blocks in that time frame, but once they started the use of nerve blocks, there were 37 falls out of the total patients that had the surgery, which was a 3.6% fall rate. So most of the falls occurred with the total knee replacements. There were 6 with the total hip replacements, but the majority were the knees. And 28 of the falls were unassisted. 4 of them were with PT, 2 with nurses, and there were 3 that involved family members ambulating the patient. Most of them, the activity at the time of the fall was toileting. That was in 22 of the cases. The other 15 cases, it was other, so they could have been up with PT, they could, there were other reasons. But so the main thing is to make sure that the patient's being toileted, do an hourly rounding check-in to see if they need toileting, because that's the highest risk of their falls. So if their bladder's empty, they shouldn't be wanting to get up to go to the bathroom at all by themselves. A lot of times the patients have the perception that it takes a lot of time for the nurse to get there, and it may only be a number of minutes, but to them that's a lot because they're used to being able to be independent with going to the bathroom. So I found some research articles that went over just falls in general and had some interventions in there that are good for, which most of them we're probably already using, but I just wanted to go over them so that we're, addressing all of them. The first article was Retrospective Case Reviews of Adult Inpatient Falls in the Acute Care Setting. It showed that multiple factors contribute to the falls, whether it's patient behavior or nurse behavior. and it causes the need for multiple fall interventions to address both the patient issues and the nurse issues. The interventions in that article is constant re-education of the patient. Every time you go in the room, you should be educating your patient not to get out of bed without assistance, to call for assistance. And make sure the patient knows that calling for assistance does not bother the staff, because sometimes they feel that way, and even though they don't verbalize that, they will just get up on their own because they don't want to be a bother. So if you tell them that specifically, they won't feel like they're irritating the staff. They'll be more likely to call for assistance. And then when the patient does call, just being prompt and responding to them, and that way they don't feel like they're being a burden. And it prevents them from transferring alone and allows them to trust you that you're going to make it there in a timely manner. The next research article is patient engagement in hospital fall prevention, and it just shows that including the patient in preventing falls is essential. So just basically including them in their own care plan, which is just nursing in general. It could lead to a decreased risk of falls. You want to utilize fall risk assessment tools. I know here we use the Morse Fall Risk Assessment. It allows for identification of risk so that you can put interventions into place. Also, maintaining the bed in lowest position, it allows the patient to have a safer bed exit. If the bed's way up in the air and they can't reach the floor appropriately, they're more likely to fall. Ensuring that the path to the bathroom is clear also helps with preventing tripping due to obstacles in the way. And that's whether they're ambulating on their own or even if you're walking with them, because if you're assisting them, you're not going to be able to stop and get things out of the path. It's better to have it clear to start with. And then the next article is the effects of an intervention to increase the bed alarm use. And it basically, there was a study or multiple studies combined that showed that bed alarms can potentially reduce falls 20 to 60%. And that varied because some of them had controls and others that, the trials themselves caused the differences in the percentages. The research article just discussed increasing the use. It wasn't whether or not to use the bed alarms, it was how to increase use among the nursing staff. So the interventions with that is to make sure that you use the bed alarm when the patient's in bed so that you're alerted of them exiting the bed. Promptly respond to the bed alarm so that you can get in there before the patient makes it out of the bed, because they move quickly. I know y'all know. Provide hourly rounding on the patients, which allows early intervention of the patient's needs, and that's exactly what I was talking about like making sure if they need to go to the bathroom and that type of thing, that's addressed so that they don't feel like they should go by themselves. And the last research article is examining evidence-based interventions to prevent inpatient falls. And it's basically that nurses are essential to fall prevention. Implementing the interventions is essential. If you're not implementing the interventions, then there's nothing to keep these patients from falling. You want to make sure that if the patient has a lot of medications that are going to put them at risk for falls, like antihypertensives, pain medications, just a multiple combination of those type of drugs, you want to make sure you're discussing changes with the provider so that they don't have so many medications that's going to cause them to be higher risk for falling. Also evaluating the need for a chair alarm for the patient. This is mostly with the cognitively impaired patients. But even sometimes it's if you know that a patient's, how do I put it, quick to get up by themselves. You can, some of them will be a little more non-compliant and impulsive. Yes, thank you, impulsive. Then they may need a chair alarm as well. And then placing fall risk signs on the doors of the room allows all of the staff to know. So even if it's like dietary or whoever's happening down the hall, if the patient's wandering around the room, they would know that they need to get help for them. Okay. So basically it's just utilizing the interventions to prevent falls, just to improve the patient outcomes and just protecting yourself from litigation and protecting your patient from falls and injury. Because besides the fact that it causes us not to get reimbursed, and it causes longer hospitalizations and us not to have beds for the other patients that need beds. It just in general, it's not good for your patient to go through that, and it causes them to have longer healing times and possible long-term complications. So, do y'all have any questions or anything to add?
No.
All right. Well, thank you for listening to my presentation.
So you keep these?